So everyone, welcome back to our discussion on the hip, and we will today continue with the muscles of the hip. So we have one and two joint muscles that cross the hip joint. One joint muscles offer stability, where two joint muscles provide a range of motion typically. Anterior muscles of the hip, those are responsible for flexion. The muscles that are on the posterior aspect of the hip are responsible for hip extension. Lateral muscles are responsible for abduction, and medial muscles are responsible for adduction. The anterior horizontal muscles are responsible for internal rotation, and the posterior horizontal muscles are responsible for external rotation. So let's start looking at some of these anterior muscles. So we have the iliopsoas. It's actually two different muscles, the iliacus and the psoas muscle. If you look over here at the left picture that we have, you see that psoas major that attaches to L5, L4, L3, L2, and L1, and then comes down through the abdominal cavity, through our pelvis, our pelvic girdle, and actually inserts right here on the femur, and thus is one of the prime hip flexors of the hip and of the femur. You also have the iliacus, which sits inside this ilium here, and that comes and that attaches at the same exact spot on the femur. And thus, since you see that these muscles do not cross all the way down towards the knee, you know that they are mainly there for support because they are one joint muscle, but they also really are the workhorses. They're the power builders of the hip. So they're the ones that really start the motion, not so much this partner next to it, the rectus femoris, which is often confused as being the main hip flexor of the hip, but it's actually not. It's actually the psoas and the iliacus, the iliopsoas as we call it. So the iliacus here, you see here, it sits on the iliac fossa, and then it inserts on the lesser trochanter of the hip. And then its main job is hip flexion, along with the psoas that does the anterior surfaces of T12 to L5, and they insert on the lesser trochanter and they do hip flexion again. And when the femur is stabilized, the psoas muscle provides trunk flexion. So like when I'm standing on both feet, when we flex our trunk and bend over, kind of like you think of like a RDL, you're working that psoas muscle a lot. And then rectus femoris, that's this big long guy here that actually runs down, creates a majority of this quadriceps tendon as it turns into the patellar tendon. And then the patellar tendon sits within that quadriceps tendon and then turns into the patellar tendon. So the origin of it is that AIIS, sorry, and it inserts on the tibial tuberosity on the tibia. Its main job is hip flexion and knee extension because it does cross both of those joints. So it crosses the hip, so it does hip flexion, and it crosses the knee, so it does knee extension. Okay, this is the only quadricep muscle that actually crosses the hip as well. So on our model here, you can see this is our iliacus and our psoas muscle. You can see here, I removed the upper portion of the guy, but you would see here, this is a vertebral column, right? Since we didn't go over it before. Here's our iliac crest, our pubic symphysis. You can see here how it's that nice joint right there. Okay, sorry, I clicked the pubic ligament up here. So it's not going to actually show me the symphysis as like the disc. It's going to show it to me as the whatchamacall, as all the ligaments that attach to it. Okay, so here's our left pubis, our left ischium here. You can see how that kind of creates, and you can see how it creates those three little sections of that hip fossa right there. Okay, so you got the ilium, the ischium, and the pubis, and then the head of the femur will sit right inside there and actually articulate with that. And then there's a labrum that makes that deeper. But look how deep that fossa is compared to our shoulder, right? So much more depth here in the hip than there is in the shoulder. And you see how, if you think of our scapula, right, how it's convex and concave, and it mainly provides attachments to muscles. If you think of this pelvic girdle that has 28 different muscles that attach to it, you can see how this iliac crest here really provides and is shaped to just support muscle. Because then as we look around, you lose it. It's gone. You lose it to all the muscles that attach to it. Okay, even on the anterior or medial side and on the lateral side. And then we have here our sacrum, the anterior sacrum, and the posterior sacrum. You see how it's convex and concave. Down here is our coccyx, right there. And then you see all the spinal nerves that run through that coccyx as well. So here is our psoas, right here, running down into the hip. Can't really see it. Like I said, it gets lost. You can't really see that lesser tubercle right there, right? Because it's lost in all this soft tissue. And then our iliacus here. This is our inguinal ligament that comes across. I was telling you guys about some hernias that can happen right there. Okay. And then this bad boy right here is our rectus femoris. And you can see how that origin once again is kind of lost in there. In that anterior inferior iliac spine on the AIIS. Then it comes down into our quadricep tendon. And then our patella. And then our patellar tendon right there. Okay? And there's the tuberosity on that tibia, where that attaches, where it inserts. Then we have our sartorius muscle. So it originates on the anterior superior iliac spine, so right at the front of that hip when we put our hands on our hips. And it inserts on the proximal medial tibia. The action of it is hip flexion, abduction, external rotation, and knee flexion. So it does a lot of actions there. And it's actually the longest muscle in the body. It's most efficient at performing all of its motions at once versus being a prime mover of any. When you do that many motions, it's kind of like a person who's well-rounded, right? So you might have a gen med doctor who's pretty good at everything, but they don't have a specialty in any one thing. That's kind of like this muscle here. It's good at hip flexion, good at abduction, external rotation, and knee flexion, but it doesn't have a specialty. So it's not excellent at hip flexion. It's not excellent at abduction, but it does help. Okay. And then we have our pectineus. Okay. So our pectineus, that actually is originating at the superior pubis, so you can see it there, and it inserts on the pectineal line of the femur. Okay, so there's a little crest on the femur that you can see, and that's what they call the pectineal line. And then there's it does hip flexion and adduction. So here's our sartorius. You can see how that comes all the way down and around, right? Starts on that ASIS up top. Whoa, my fault. The ASIS right there. Then it comes down and inserts on that tib tube down there. Okay. And then we have our pectineus right here. You can only see a little piece of it. Sorry. Zoomed out. Because you lose it. I'm going to unhighlight it. And it's right here. And you lose that sucker as it goes in underneath that sartorius. Do you see that? See how it originates on that superior pubic right there, superior pubic bone, and dives down in. If you look at that line of pull, you know it's going to do a little bit of hip flexion and a little bit of adduction because it's just how it's shaped and how those fibers are aligned. Okay, then we have our adductor group. So we just kind of throw these all together. Adductor longus, brevis, and magnus. Magnus is the widest, as you see here, so it does a good amount of that adduction, whereas these other little adductors, adductor longus is just a long muscle. Brevis, in my opinion, is not much shorter than the longus, and then magnus right here spans that whole medial femur for the most part. Okay, they all originate right up there on the pubis, and then they insert on the linea aspera, which is just this kind of little groove on the femur that you'll be able to see on Hank in class. You can really see that linea aspera. You can't palpate it because it's covered by so much muscle, but it's there. So let's see if we can find it on our man here. So there's longus, okay? And then you see how we really lose it under all here. There's magnus, you can see just a piece of it right there, but you can see that massive origin here. Okay, so that means, you know, we have a very wide base, and you can see that, how it's going to come down. You can kind of see a little of it hidden underneath here. Let's see if I take these off, we can see a little better. Oh, I just broke it. There's magnus there. You can see how it's sitting under there. It attaches. You can see the blood vessels and everything. Look how big that one is right there. It's a pretty thick muscle that sits inside there. A lot of people point to, they're like, I pulled my groin, but really it's this gracilis here when they feel that. Sometimes this adductor longus. A lot of times they don't really get this adductor magnus. They'll almost say it feels more like a hamstring strain, and they say it's kind of almost up in their crotch, but on the posterior aspect. Just a little 2 cents. I don't think we have the brevis up here. I think it's too hidden for us to see. Yeah. Then we have the gracilis, which I just showed you guys, right? And it originates on the pubis, and it inserts on the proximal medial tibia. Its main action is adduction, and it's the only adductor to cross 2 joints. So it crosses up here at the hip, and crosses the knee. And then we have the glute maximus. It's the posterior sacrum, the whole thing, to the ilium. Posterior femur to the distal greater troch, and then it does hip extension and external rotation. Okay, so let's take a look at that. So our gracilis right there. See how it starts up here at the pubis, and then goes down below the knee. Right there. It starts with all those other adductors, the sartorius here, some of our hamstrings here, and it just inserts right there. I'm not going to dive into that origin too much because we are going to cover that when we talk about the knee next week. And then here it is in all of its glory. The gluteus maximus right there. Okay, see how that makes up the majority of our posterior there. Now something interesting kind of about it is look how big this muscle is on most, right? So, and it attaches to the sacrum. So a lot of times if you get a very strong contraction, it attaches to the sacrum, which sits as a wedge within this pelvic girdle, right? So if you get a strong contraction, it can easily rotate this, causing dysfunction in this pelvic girdle all around, in the hip flexors, the adductors, the hip extensors, all because of what we talked about before, how there's this counterbalance and kind of conundrum like uh, swinging back and forth of this pelvis. So if one side squeezes too hard, it's going to mess up the function and movement patterns of the entire body, really, when the pelvis is off. So that could happen. So that's just kind of something interesting to work with when you start looking at the glute maximus. Then we have the hamstring. So we're going to look at 3 different muscles for the most part here. We're looking at the semimembranosus, the semitendinosus, and then the biceps femoris. So if you think of it this way, right, I said earlier that the knee and the elbow are very similar, right? And then the hip and shoulder are very similar. So what does our biceps do? It flexes our elbow. So what would our biceps femoris do, right? It does the exact same thing. It flexes our knee, okay? And just like it does some shoulder flexion for us, because it's on the posterior of the hip, it's also going to do a little bit of hip extension, okay? So just something to remember. You see it right here on that lateral side. And then on the medial side is our semitendinosus, okay? And our semimembranosus. They kind of sit over each other here. Okay, you can see here. So here's our semimembranosus. It comes down, and then the tendons attach in the same spot on the anterior portion of that knee. So right here, and then, so I guess I lied on this band here, but if you just know that they cross each other, and they both shoot in right there. This is the semitendinosus, semimembranosus. So when you're palpating distally, you can kind of lose those. You can feel it when if you sit in the chair and try and flex your knee and feel the medial tendons. You'll feel them right there. You'll feel 2 of them popping, and those are your semimembranosus and tendinosus. At your level there, you're not going to be able to differentiate between the 2, but they are there. So it doesn't, that's okay. You don't need to differentiate between the 2. Just like as you move into the belly, you're not really going to be able to differentiate with the minimal palpating that we do in lab. You're not going to be able to identify those. But know that the semitendinosus is a little bit more a little bit more lateral in terms of how we're looking at it, right? And then the semimembranosus is a little bit more medial, okay? And then, if we look at the outside, here's the biceps femoris, okay? And that inserts on the medial portion, or the lateral portion of the knee right there. Okay. Then we have our deep rotators. Okay, these are, in my opinion, one of the least worked and overlooked portions of the hip. I work these a lot with a lot of knee pain and ankle instability people because of the fact that they are often overlooked by their big brother, the glute maximus, right? The glute maximus does hip extension and external rotation, but it's such a large muscle, it only does, think of the large muscles. What do the large muscles usually do? They create the full range of motion, right? But the little guys are the ones that do all the force. They create the power there. And these do hip extension. The piriformis is the best known deep rotator, and it can often compress the sciatic nerve, which could cause some shooting pains down your leg. And the origins all differ. The attachments are irrelevant due to the same action of the muscles. Okay, so you can see here how they all originate at different portions of the pelvis. Here, some on the sacrum, some on the ischium here. Okay, they all kind of attach right here on the neck of that femur. Let's see if we can dissect our person here and take a look. Okay. So let's hide the glute. And there we go. Look at that. Okay. So you can see this big bad boy right here is our sciatic nerve, thick nerve. Look at these little white nerves here. Look at this thick sciatic nerve. So you can see how all these, let me get rid of some of this connective tissue here too. Okay, let me actually take this guy. Let me see what's going to happen if I do that. I'm going to keep it back on. But you can see here, all these little rotors. See how it originates on this ischium right here? You have this obturator there. You have this inferior gemellus, our superior gemellus, our piriformis right here. You can see how that guy can compress the sciatic nerve because it shoots right underneath there. So you see that? So if this guy gets tighter and inflamed, it's going to compress that nerve, causing some pain. Okay, glute minimus there. I'll show you that in a minute when I take that layer off. So glute medius, which we just got a preview of. This is, we're moving kind of lateral to the hip now. Glute medius does the outer ilium to the lateral greater trochanter, and then it does hip abduction, similar to the deltoid of the shoulder. Okay. Then we have glute minimus. Okay, that does the lateral surface of the ilium, and it inserts on the greater trochanter, but the anterior portion, right? So here and then here. So this is the minimus, medius. And then does hip abduction and internal rotation. Okay, because you can see how these kind of rotate here. See these fibers, how they curve a little bit? So the medius does straight abduction because look at their fibers. Meanwhile, the minimus, it rotates. It's a little bit more anteriorly positioned, so it can create a little bit of that hip internal rotation. It's deep and inferior to the glute med. The glute med and glute minimus work to stabilize the pelvis when standing on one leg. A lot of times if you stand on one leg and you see the hip pop out, it indicates that one of these two is dysfunctional. Then we have our TFL, our tensor fasciae latae. You see that right here. It's mostly connected to this IT band, which is just a strong, thick piece of connective tissue. It originates at the ASIS and it inserts on the lateral condyle of the tibia. The action is hip flexion and abduction, and it's the strongest in abduction when slightly anterior due to the line of pull. So let's look at those here. Okay, so boom, glute med right there. So you can see how all those fibers sit there, and this is our IT band right here. Okay, and then if we're looking at the IT band, you can see right underneath it is the TFL right there. So if I put it back on, you see how it's attached and becomes almost one with that IT band, right? Then we have our glute med here. Take that off, and then you see the glute minimus right there underneath it. Still a large muscle. There's nothing minimum about it, but to be able to do the things we do, that's the muscle that we rely on. So when we look at arthrokinematics of the joint, it's open packed at about 30 degrees of flexion and 30 degrees of abduction. So just a little bit bent and a little bit out with a little slight external rotation. It allows for maximum joint surface movement at this position. And then once again, since we do have a ball and joint, just like our shoulder, right? It does the same convex concave rule that the shoulder does. Okay, so as the head of the femur glides one way, the bone goes the other way. So you think of extension, how our leg would go back while the head of our femur would roll anterior. And then vice versa. The head of our femur would go posterior as our leg would come up. Some common pathologies. hip anteversion and hip retroversion, right? So we're looking here at this anteversion here, and the head of that, or the greater trochanter, is a little bit anterior. And then retroversion is where the head of the greater trochanter is posterior. You can see here the neck and the condyles, how the angle is more open, and then how it's closed with retroversion. Using an assistive device, it's often placed in the opposite hand. It increases the base of support and unloads the effective side. So you see how instead of just our feet here, our base of support is now from the assisted device and the standing leg, weight-bearing leg. And then we usually provide an upward force of a cane prevents the lateral tilt of a pelvis. So it prevents this from completely dropping by widening that support, allowing this to create some support for us. And as we push down here, it pushes us back, thus stabilizing this and prohibiting the trunk from just falling down. Okay, so that's all we have for today. Quiz, I'll make it again due on Monday due to the late posting of this video here. I appreciate all of your understanding with that. The practical kind of threw me off. I didn't want to put the video up earlier in the week because I knew, one, most of you guys aren't going to watch it. Two, I just didn't want you guys to feel overloaded with the practical studying that and then being like, oh my gosh, I have a test also and videos to watch for this week as well. Okay. The knee will be posted tomorrow and Monday for the 2 parts there. I'll probably do the knee as one video and the ankle as another video just to help break it up. And then in lab, we're going to go over everything, okay? And then we will have a practical in 2 weeks, just the same format as we've been doing in the first one as well. I think you guys did really well there. You guys understand what's going to happen in the practical, so you guys should do even more awesome than you already have done. All right, keep up the good work, hang in there, and I will see you guys in lab on Wednesday and Thursday. Take care, guys.